Hello guys, I am back with another video and today I am going to explain congenital heart abnormalities. So let us begin. So guys, basic principles. So these type of defects they arise in during embryogenesis, often between 3 to 8 weeks, which are important for the development of the fetus. Now, most defects are sporadic and they often result in shunting between the left and right circulations. Okay, so imagine it like this. Uh, if there is a defect in the ventricular septum, which divides the right and left ventricle, okay, so blood will go from high pressure system, that is left ventricle, to the low pressure system, which is right ventricle, okay. So it will cause cyanosis of the peripheral organs, okay. Now, defeat with left to right shunting may be relatively asymptomatic at birth, but the shunt can eventually reverse. Okay, so how will this shunt reverse? Okay, so imagine this is our heart. Okay, this is the septum joining. This is the right atrium, right atrium. This is the left atrium. This is the right ventricle. This is the left ventricle. Okay, so there is this defect. Okay, so the blood will go from left ventricle to the right ventricle. Okay, so now there will be increased pressure on the right ventricle. Okay, so it will cause the hypertrophy of the right ventricle. Okay, so that will cause the right ventricular hypertrophy, and this is eventually very dangerous for our body. Okay, and increased pulmonary resistance eventually results in, in reversion, causing late cyanosis, Eisenmenger syndrome, which we call Eisenmenger syndrome, with the right ventricular hypertrophy. Okay, polycythemia. Now, why do we have polycythemia? So, guys, polycythemia is basically increase in the RBC in the blood. Okay, so does this happen? Because not enough blood is being pumped by the left side of the heart. Okay, so it will cause the bone marrow to, sorry, the kidneys to produce e- erythropoietin. Okay, so EPO will stimulate the bone marrow to produce more RBCs. Okay, as the blood is not sufficient to perfuse to the bone marrow, so it will produce more RBCs, and it will cause the polycythemia. Okay, and clubbing means like this cyanosis, blue discoloration of the skin. Okay, and defeat with left shunting usually presents as cyanosis shortly after birth. Okay, in this diagram you can see the atrial septal defect, ventricular septal defect, and the period. That is a patent ductus arteriosus. Okay, we, we, we will discuss this soon. Now, ventricular septal defect (VSD). So what do we have in this? It is the defect in the there is some defect in the ventricular septum. Okay, as you can see in this diagram, this is the ventricular septum, and there is some defect. So what will eventually happen, that the blood from the left ventricle will go into the right ventricle, causing the Eisenmenger syndrome. Okay, and it is the most common congenital heart defect. Okay, and it is associated with the fetal alcohol syndrome. This is very important, guys. Fetal alcohol syndrome. Okay. Now, it results in left right shunt. Size of the defect determines extent of shunting and the age at presentation. Okay. And small defects are often asymptomatic, but large defect can lead to Eisenmenger syndrome. Okay. and treatment involves surgical closure. Small defects may close spontaneously. Okay. Now, atrial septal defect. Okay. So as you can predict from the title, that the atrial septal, it means that there is some defect in the septum of the which divides the two atria, right and left atria. Okay. So we have two types of septal defects: ostium primum and the ostium secundum. Okay. In the most common type is the ostium secundum. Okay. And the ostium primum is associated with the Down syndrome. So this is also very high yield. Okay. And it causes left right shunt and a split S2 on auscultation, increased blood in right heart, delays closure of pulmonary valve. Okay. And paradoxical emboli are an important complication. Okay. So what do I mean by by the paradoxical emboli? Okay. So guys, you might know that if you have DVT, that is a deep in thrombosis, it can eventually cause the pulmonary embolism. Why? Because the emboli will travel from the inferior vena cava or superior vena cava to the right atrium. Then it will follow the course like right ventricle and then the pulmonary trunk. Okay. But in this case, what will happen that there is a shunt in between the right and the left atria. So the emboli will travel from right to left atria and then the left ventricle and then towards the aorta and it can cause cerebral stroke, all those kind of stuff. Okay, renal stroke, all those. Okay. Now patent ductus arteriosus (PDA). Now what is this patent ductus arteriosus? It is basically the a vessel which connects the pulmonary trunk to the aorta. Okay, and as soon as the baby is born, this PDA it starts to wither off. Okay, and in some babies there is failure of PDA to close. Okay, and it is associated with the rubella, congenital rubella. Okay, this is very high yield. Okay, and results in left right shunt between the aorta and the pulmonary artery. Okay, so I will give you context to, to, to this. See guys, this is the normal heart. Okay, and this is right and right, right and right and left atria, right and left ventricle. Okay, this is the pulmonary artery. Okay, and this is the aorta. Okay, and this is a PDA, that is a patent ductus arteriosus. Okay, so as soon as the baby is born, the this PDA it starts to close off. Okay, but in some individuals, between some babies, it doesn't. So it will cause a left to right shunt. Okay, and it may lead to Eisenmenger syndrome. Okay, resulting in lower extremity cyanosis. Okay, asymptomatic at birth with continuous machine-like murmur. Yeah, this is also very high yield. When we auscultate the the heart, we find the machine-like murmur. Okay, and may lead to Alzheimer's resulting in lower extremity cyanosis. Okay, guys, the PDA. Yeah. Now the treatment involves indomethacin, which decreases PGE, which keeps the PDA closure. Okay. PGE maintains patency of the ductus arteriosus. Okay. PGE keeps the ductus arteriosus patent. Okay, you can learn it like this. PGE keeps the patent ductus arteriosus intact. Okay, so if we decrease the PGE, it will cause um the removal of the PDA. Okay, now tetralogy of fallot. So as you can guess by the name, it has four pathologies. Tetralogy. That means four. So first, it is featured like there is a stenosis of the right ventricle outflow tract. Okay, so there is there is narrowing of the right ventricular tract. Okay, and eventually it will cause the right ventricular hypertrophy, and and also there is VSD, that is a ventricular septal defect, and an aorta that overrides the VSD. Okay, so you can see in this diagram, this is the condition of heart in the tetralogy of Fallot. Okay, now right to left shunt leads to early cyanosis. Right to left, right to left. Okay, um, degree of stenosis determine the stenosis shunting and cyanosis. Okay, patients learn to squat in response to cyanotic spell. Why? Because whenever we squat, the venous return to the heart increases. Okay, so that that increases the heart rate and eventually causes the cyanosis to stop. Okay, and yeah, which increased arterialization decreases shunting and allows more blood to reach lung. Okay, and there is a picture in the X-ray. We can see the boot-shaped heart on X-ray. Okay. In the next video, I will discuss the transposition of great vessels, bronchus arteriosus, tricuspid atresia, and the coarctation of aorta. Bye bye. Thank you. Which of the following is associated with fetal alcohol syndrome? Option 1, VSD. Option 2, ASD. Option 3, PDA. Option 4, coarctation of aorta. So pause and try to answer this question, because I have answered this question in my previous slides. So please try to answer this question, and the answer is VSD. Okay. Thank you and bye.